So next, Dr. Amy Smith is our next speaker. She's a board-certified physician in pediatric hematology and oncology with special training in pediatric neuro-oncology. She completed her training at the Children's Hospital in Denver, Colorado. And before she became director of the pediatric neuro-oncology program here at the Cleveland Clinic, she served as director of pediatric neuro-oncology at the University of Florida Shands Children's Hospital, and then also as director at the Orlando Health Arnold Palmer Hospital for Children. She has experience in developing and running clinical trials from phase 1 to phase 3, has been vice chair of the ependymoma subgroup on the CNS steering committee since 2014. She's committed to providing outstanding care to children with pediatric central nervous system tumors, as well as developing new treatment approaches through clinical translational research and supporting the education of the next generation of pediatric oncologists. Her efforts in patient care research and education are focused on and fueled by the goal of improving survival and quality of survival for children with brain and spinal cord tumors. And Dr. Smith will be talking about therapeutic interventions for neurofibromatosis and schwannomatosis. So Dr. Smith.
Good morning. Thank you for having me today. So today we're going to talk about therapeutic interventions in neurofibromatosis and schwannomatosis, and I think we'll harken back to a number of things that were addressed in the first talk today by Dr. Lucas, where she was addressing the molecular abnormalities that have been uncovered for NF1, NF2 associated schwannomatosis and schwannomatosis. So just as background, without going into a lot of detail, but just reminding us that NF1 has an incidence, it's pretty common, of 1 in 3,000 people. There's a constellation of clinical findings: cafe au lait spots, axillary freckling, neurofibromas, learning disabilities, bone deformities, optic pathway gliomas, and hypertension in these patients, and that there's a mutation in the NF1 gene that's located at chromosome 17, which produces a lack of neurofibromin that then causes the brakes to not be able to be placed on, so that you end up with uncontrolled cell growth that can lead to tumors. 50% of children will develop non-malignant tumors on the nerve sheaths that are called plexiform neurofibromas, and these can cause significant pain, mobility issues, and changes in appearance. NF2-associated schwannomatosis, which was formerly known as just NF2, is much less common, with an incidence of 1 in 25,000 people, and presents with bilateral vestibular schwannomas, meningiomas, and spinal ependymomas throughout the CNS. And there is a mutation in the NF2 gene that's located on chromosome 22, causing a lack of Merlin that again results in uncontrolled cell growth, leading to these tumors. Schwannomatosis is even less common, ranging from 1 in 40,000 up to 1 in 70,000. These patients have multiple schwannomas, meningiomas throughout the body, and there are mutations have been identified in SMARCB1 and LZTR1 genes. Since we're going to focus in this talk really about therapeutic interventions, I really like this algorithm, because when we're trying to make treatment decisions about how to manage patients, even though we've been able to identify molecular targets, we first have to back up and ask what's going on with our individual patient, and do they need intervention. And so this algorithm really looks at patients with NF1 and their related plexiform neurofibromas, and many of these patients will have asymptomatic plexiforms, and so those patients can be observed, and you can consider annual imaging and clinical evaluation as you need it, versus those patients who are symptomatic. And then it's important to look at organ compromise, whether there's progression clinically, radiographically, if there's disfigurement, or if there is significant pain. And this is so important that we have multidisciplinary clinics where we're evaluating patients together to make decisions. As you've gotten the opportunity to hear about some surgical interventions that are options, some symptomatic surgical interventions such as the hearing interventions that can be applied. And so it's important if you have something that's causing visual loss or having tracheal deviation, maybe from a large plexiform in the neck, that there's input from the ophthalmologist, the ear, nose, and throat physician. If there are things in the chest or abdominal cavity that the other general surgeons, urologists, cardiologists are looking at these patients. There are common bone abnormalities, so orthopedic surgeons are also critical in caring for these children. And of course, neurosurgeons and neurology as we look at neurologic dysfunction. And so if there's the opportunity to get a complete surgical resection for a plexiform that is problematic, then that should be considered. If you can't do that, then molecular targeted therapies should be applied. And so in the last 5 years or so, we've had a really nice revolution with the advent and discovery and clinical trials showing benefit in using MEK inhibitors for NF1 patients who have inoperable symptomatic plexiform neurofibromas. So the first drug that was approved was selumetinib, known as Koselugo, that was approved in April of 2020, and it was approved as first-line treatment for pediatric and adult, or initially just for pediatric patients with inoperable plexiform neurofibromas down to the age initially of 2 years, now down to age 1. And more recently, in the fall of 25, the adult study also met criteria for it to become FDA approved in that population. And you can see below, the COMET study is for adult patients. So 20% of adult patients in the Koselugo group achieved greater than 20% volume reduction versus 5% in a placebo group from baseline. The SPRINT trial was a pediatric phase 2 trial that showed that 66% of patients achieved a greater than 20% volume reduction. And again, this was approved in 2020. These responses were centrally confirmed at subsequent assessments at 3 and 6 months. There's been a more recent approval of mirdametinib, which goes by the name Gomekli, approved in February of 2025. And this also has been approved for both children as young as age 2 and in adults. And these patients roughly received a 40 to 52% tumor shrinkage in clinical trials. As you'll see, there are other MEK inhibitors that are out there, binimetinib, trametinib, cobimetinib as well, but it is mirdametinib and selumetinib that are FDA approved for this indication. It's so important when it's exciting that we have these new agents, but it is really important that we learn how to monitor and manage the toxicities and have these discussions together when we're considering starting the treatments. The common side effects that we monitor for in MEK inhibitors are left ventricular dysfunction, ocular toxicities, which can include retinal vein occlusion, retinal pigment epithelial detachment, gastrointestinal toxicities, primarily diarrhea, skin toxicities, which really manifest themselves mainly as acneiform rashes, but also can be maculopapular rashes as well. Elevated creatinine phosphokinase, increased levels of vitamin E, and risk of bleeding, specifically with Koselugo, as the capsules have vitamin E, and embryo-fetal toxicities. Gomekli, this is a little bit of their data in pediatric patients. They had 114 patients that were studied. 52% of them had plexiforms that shrunk by at least 20%, and almost 50% shrunk by more than 50%, which is pretty dramatic in this population. For those of us who have cared for patients for many years, this is so exciting to see these kinds of responses. The other thing that's important to pay attention to is how long does it take? Sometimes it's easy to get impatient and think that if you haven't had a response in the first couple of months that maybe it's not going to work. But it was shown in this study that the tumor shrank anywhere from between 4 months on the drug all the way out to 19 months on treatment. And so sometimes it's important in these tumors to have patience while you're awaiting response. 85% of the children eligible to continue on the treatment after it was done at 2 years, they chose to continue taking the drug, which I think speaks to tolerability quite well. 9% of the patients on study did have to stop during the therapeutic planned treatment due to a side effect. This is a drug is supplied as a capsule, tablet, dispersed tablets that can be made into an oral suspension for younger children and can be taken with or without food. This is the adult data for Gomekli. The primary endpoint was overall response rate. There were 41% of patients achieved a confirmed response, which was defined as greater than 20% reduction in the volume of the tumor. And of the patients with a confirmed response, 62% had what they refer to as a deep response, which is greater than 50% reduction in volume. And the patients who were able to achieve that deep response had a longer duration of treatment than those who did not. And then over to your right is really just a waterfall plot, which basically shows that below the line, that's the percentage of response of the tumor. Anything that's above are patients who had a little bit of progression. And again, the monitoring and toxicity is similar to selumetinib with ocular toxicities, left ventricular dysfunction, gastrointestinal, skin toxicities, and embryofetal toxicities. I focus on the skin toxicity here as this is in both drugs and also other MEK inhibitors often one of the reasons patients come off treatment. In this population, 90%, only 90% of patients had some sort of skin toxicity, 10% had a grade 3. And 73% of the pediatric patients experienced some sort of skin toxicity, with 3.6% of them experiencing a grade 3 toxicity. So there's a question now is, since we can get response, is can there be transition to prevention? And there's an active clinical trial being run investigating if early intervention with selumetinib can prevent peripheral nerve growth in high-risk infants before the symptoms appear. And so this is a phase 2 study that is being run for children between the ages of 1 and 8 years. It's currently accruing and recruiting patients, and it's open through the Neurofibromatosis Clinical Trials Consortium. And then I thought I would also address optic pathway gliomas that occur in NF1. These can occur in up to 15 to 20% of children who have NF1. And even though they're present, visual deficits are really only occur in less than half of these children. And it's important as we're making treatment decisions that the goals of treatment are really preservation of vision. The determination of who needs chemotherapy or some intervention can sometimes be difficult because assessing vision in small children is not very simple. Carboplatin chemotherapy is still considered the standard of care for newly diagnosed patients. However, there is a randomized trial currently open through the Children's Oncology Group, randomizing patients between standard chemotherapy versus selumetinib. However, there was a nice phase 2 trial that I'll show in just a second where MEK inhibitors have shown excellent response in patients with NF1 and optic pathway gliomas in the recurrent setting. Additionally, bevacizumab is an agent that has been shown in retrospective reviews and even a very large retrospective trial that you can often get more quick response to improving visual acuity with the use of this agent. And one thing that I want to speak to also is that as we been running all of these clinical trials, and our functional outcomes, particularly visual outcomes for optic pathway tumors, is so important. There's been a large effort to develop a more standardized way to assess response, both radiographically and incorporating visual functional outcomes for these children. It's called RAPNO. It's been published, and we're, as a community, working to how to incorporate this as we go forward and can sort of standardize and understand what the benefits are for the different trials. This is just a quick glance at the phase 2 trial that was run for children with using selumetinib in children with BRAF aberrant or NF1 type recurrent or refractory tumors. This was run through the Pediatric Brain Tumor Consortium and showed a really excellent response and duration of response for children with optic pathway gliomas in the setting of NF1. For NF2-related schwannomatosis, there's nothing that is FDA approved for this, and Dr. Lucas mentioned earlier that brigatinib is an interesting agent. It targets ALK fusions and is used in other cancers, and it's being studied in the NF2 schwannomatosis. 40 adult and adolescent patients show that 10% of growing tumors and 23% of all the tumors did shrink in response to brigatinib, and so this is becoming a drug of interest for this population. And then the question is, what's coming forward, and is gene therapy, because these are single gene diseases, although the genes are quite large and it's very complicated, but there has been some research that was recently published that there is a group at Johns Hopkins that is successfully bioengineered an AAV vector that can carry the large NF1 gene, and they're in the animal model stage of this, but there is hope that something like this will come to people in the next several years. And so future directions and conclusions, I think that hopefully we'll be looking at not just single drugs, but maybe combinations of drugs together. There will probably be additional neurogeneration with lower toxicity profiles. Hopefully gene therapy is coming at some point. And additionally, as we have longer and better survival in our children, it's so important that we are developing adult NF centers, and so that we can continue to advance these treatments as the children age. Thank you.